Welcome to my YouTube channel. My name is Wangoi Mwangi, and today we are doing episode 2 of our midwifery series. This is Nursing with Koi, and this is an informative channel that provides education on various topics of nursing and various diseases. So I will be covering midwifery as a whole episode, a whole series of 10 episodes. So we are doing episode 2 today. If you are new to this channel, please take your time to subscribe and hit the bell icon so that you're notified every time I upload. And interact with me in the comment section below so that we can continue learning together and I can cover topics that are actually relevant to your specific needs. So let's dive right in. So this episode 2 is about antenatal clinic or antenatal care, and this is what we are going to be discussing, and I will try to make it as concise as possible because there is so much information that could be covered that is all important. So there are so many terms I could want to define, but I chose to define only 6 to avoid so much content on the video and the video being unnecessarily long. So one is antenatal, and this means before birth. Ante is before, natal is to do with pregnancy, so it has to be before birth, during, or relating to pregnancy. Antenatal care is care given to pregnant mothers before their baby is born. Then postnatal care, of course, is care given to the mothers after or following the birth of their baby. Maternal deaths is the death of a woman while pregnant or within 42 days of termination of pregnancy, irrespective of the duration and site of pregnancy, from any cause related to aggravated by the pregnancy and or its management, and not from accidental or incidental causes. So then, if it's an accident, let's say they were in a road traffic accident, that is not counted as part of maternal deaths because that's now accidental deaths caused by trauma. Maternal mortality ratio is the number of maternal deaths per 100,000 live births, while neonatal mortality is a death that occurs within the first 28 days of life between day 0 and day 27. Then neonatal mortality ratio or rate is the number of neonatal deaths per 100,000 live births. So it is important to have these things now up front to know a little bit about them. We are going to be covering them in the future series, but the main focus of antenatal care is to prevent maternal and neonatal mortality, to reduce those numbers and eventually have the Beyond Zero campaign, or zero deaths of mothers and zero deaths of babies. So an analysis of the situation on the ground, vitu kwa grao ziko hivi. In Kenya, complications of pregnancy and childbirth and puerperium are the leading causes of inpatient morbidity and mortality in females over 5 years of age. And these were facts and figures of 2009. This number could actually be more. Then maternal mortality levels in Kenya have remained unacceptably high at 488 per 100,000 live births, with some regions reporting over 1,000 births out of 100 live births. Neonatal mortality, on the other hand, is about 31 per 1,000 live births, and that was according to the data in 2008-2009. I didn't get the data for this. I think there's another survey that was done in 2019. I should be getting those statistics, and I think I will link them somewhere. Currently in Kenya, neonatal mortality rate contributes to about 60% of all infant mortality cases in Kenya. So there are 3 distinct levels in which delay occur, causing maternal and neonatal deaths. And these include the following. 1, delay in deciding to seek appropriate care, and this is on the part of the patient. They do not know that they need to seek health care, so they wait until it is too long, and this could be due to socio-cultural barriers, failure to recognize danger signs, failure to perceive severity of illness, and cost considerations. Those are some of the reasons why people will not seek care even when they do need it, without their knowledge or without having to know how serious the situation is, basically. Number 2, the delay in reaching appropriate healthcare facility, and this is due to long distance to a facility, poor condition of road, lack of transportation, and cost consideration. I have said, I think in my first video in episode 1, that it is unacceptable where we have an expecting lady who cannot access a health facility because they do not have means of transportation. It is still happening even in 2021. This has been brought down. The numbers of women who succumb because they didn't get to the hospitals have been reduced significantly by the Beyond Zero campaign, the mobile clinics. But even with the mobile clinics, we still have women who are not able to reach the facilities. What the Beyond Zero campaign mobile clinic does, they take labor ward to the people who cannot get to the hospital. So they park by the community, awaiting for anything that will arise, any emergencies, and then they handle them on site, and then they continue with their journey as they proceed. So sometimes the terrains can be too bad, and the Beyond Zero campaign mobile clinics are not able to pass through, and this could also lead to unnecessary loss of life. Number 3 is delay in receiving adequate emergency care at the facility, and this is due to shortage of staff, supplies, basic equipment, and skilled personnel, user fees, among other things. So the status of intervention already existing to reduce maternal mortality and morbidity include approximately 9 out of 10 of all pregnant women in Kenya attend at least one antenatal visit or clinic visit from a qualified healthcare provider. But only 56% will make 4 or more antenatal visits. This is very important because if especially you work in an antenatal clinic, it is important to remember that the first visit is very, very important because you do not know whether you are going to see this lady again before they deliver that child. And then, however, only about 44% of all deliveries are attended by skilled healthcare providers. I think this number is a little bit more now that we have the Beyond Zero campaign. I will try to get data that is more updated, and I will update us as we continue with this series. A way back, like 2 decades back, we had the delivery by skilled attendants progressively declining instead of increasing. But right now, that trend has changed, and we have a lot more women accessing healthcare, especially after 2013, the initiative to provide free maternal services. Then majority of births that are therefore occurring at home with no skilled attendants are quite a lot. But at least something has been done, and this is improving with the Beyond Zero campaign initiative plus the free maternity services policy that was implemented. So when talking about antenatal care, it is important to remember that we are trying to prioritize because we may not have enough facilities, enough staff, enough skilled healthcare workers to handle every pregnant woman in the country. But the WHO came up with guidelines, and these guidelines were adopted by the Ministry of Health, and there is something called Focused Antenatal Care, or FANC in short. So Focused Antenatal Care is a very good initiative because it has helped a lot more women access healthcare and know when to actually seek for healthcare services and what to do at home on their way there. So focused or targeted ANC refers to minimum number of comprehensive personalized antenatal visits. So in the Kenyan scenario, our FANC usually advises women to come for 4 visits. But in the first visit, that is where you do a lot of things, because first-time mothers should be always separated so that you are able to actually help them gain more information, do a lot of health education, do an individualized birth plan, plan for contingencies, because a pregnancy usually will take about 9 months. And this time, if your terrain is bad and you are in places where you cannot reach or get to hospitals because the transportation can't get to you, I would advise you to actually seek help from somebody, neighbors, people who are closer to the hospitals, so that you're not at your time of delivery and you cannot get through the road or whatever hill you come from or whatever valley. It is just important to access healthcare when you can, because you need it. So the focus on birth preparedness and on individual readiness to handle complications has been emphasized with FANC, and many women can still not come for the 4 visits, as we have seen with the data that has been done through research, and therefore the antenatal care should be simpler, safer, friendly, and more accessible. This is very, very important because lives have unfortunately been lost because of gaps in this provision of care and health care seeking behavior. So women are more likely to seek and return for services if they feel cared for and respected by their providers. This has improved again, and the government has tried to increase the available number of healthcare professionals within the county governments, because when the county governments came, there was services reaching more to the community members, because now with the decentralization, the county governments had the mandate to actually, they were actually allowed to hire even more nurses, more midwives, more doctors, more healthcare providers. But despite even having this provision, the number of healthcare providers available are still so low compared to the population. So FANC is healthcare given to a pregnant woman from conception to the onset of labor. It is personalized care provided to a pregnant lady, which emphasizes on the woman's overall health, her preparation for childbirth, and her readiness for complications and emergency preparedness. It is timely, friendly, simple, and safe service to a pregnant woman. So with FANC, this small book or booklet was introduced, and there are different versions of it. I have to, because I have two babies. The first one is the MOH 216 and there is a 2010 version. And then this one is this one is actually was provided from KNH, and it's KNH 543, and still it's a revision that was done in 2016. So these small booklets have come in handy to focus the care even more, because it provides health education to the mom from the point of contact, from the very first visit, and it continues to provide information until your baby is 5 years of age. So it is important, if you have any of these booklets for your children, you preserve them well and keep them for as long as you can have them, even after the 5 years, because the information contained in this is very helpful and useful, and it can actually empower you as a mom to make better decisions and to know what to expect when. So if I could just simply go through whatever it is important to notice these topics. All these things are covered within this booklet. And the first one is about the child's information. The maternal profile is the second one. Then there is history that is taken about the medical and surgical history, the physical examination of the first visit, the weight of the date. There is the weight for date chart. There is an antenatal profile. There is the infant feeding. There is the preventative services. There is the TT instructions or tetanus toxoid. There is care during pregnancy, danger signs during pregnancy, delivery. Then that continues all the way until, and it gives you even spaces for when to go to the doctor. And once you go, your doctor don't require another booklet or card, because this place has places where the doctor can write. So like the last time I went to a doctor, it was written here and they clerked me and I was given my treatment. So I don't even have, let's say if I'm in the village, I don't have to get any other resource, because I know there's those places where you will go and you're told go buy a small book or an exercise book for you to be seen, because that's the only form of health records that can be maintained. However, with this booklet, focused antenatal care is now possible, because it gives you a lot of information. What they're going to do for you until your baby turns 5 is indicated here. Those individualized birth plan usually comes in very early. You are given there is usually the child's information, because this booklet essentially is for the baby. Eventually it should be like their card, like what used to be asked for baptism. They used to ask for your immunization card. This is still the thing you will use for immunization. If it is going for hospital for family planning, it is still this book you're going to use. So it gives you a lot of information, and there's a section where we do the individualized birth plan. So if you do an individualized birth plan, and there's a section where you're supposed to invite your significant other or your spouse, and you plan together. And when you come with your spouse, always in the maternal child health clinic, FP clinic, you are given priority. You will not queue. And if you're many couples, you're just going to queue among the couples. You're given priority service because we know that the providers, the both parents of that family or that household are with us in the hospital. So usually any place where you find yourself going with your husband, especially in the government facilities, you will be prioritized if you go with your spouse, because this includes the father, the mother, and the baby. So this is a very, very important document and has helped implement FANC a long way. So the objectives of FANC, and remember FANC is Focused Antenatal Care, is early detection and treatment of problems, of course, within the antenatal period, prevention of complication using safe, simple, and cost-effective interventions. What this means is those measures that will be taken. For example, let's say you have an infection, or God forbid, your blood levels are low, or whatever is happening within you. They are able to provide safe, simple, cost-effective intervention. Let's say you're told to take prenatal vitamins and you're not able to afford them, because that's a thing that happens here in Kenya. If you're not able to afford prenatal vitamins, that you have to buy the expensive ones, the government has already provided these things for you. And in short, they're called IFAS. So every visit when you go, you get IFAS given for free, and they have simplified it. Before IFAS, we used to have iron sulfate tablets and folic acid tablets separately, and you would go and find one is there, one is not there. But nowadays they have combined these two in one small tablet. So even those women who say they are not able to swallow the big capsules or the big liquids or the whatever, the formulation is actually very user friendly. If I'm like in the first trimester when nausea is so much, then IFAS is really more palatable because it's a very small pill to the size of a family planning pill. So it's very, very small and it's very effective and user friendly. Then birth preparedness and complication readiness. This is what is going to prepare you. You have already a booklet that has a lot of information in it. Then we have health promotion using health messages and counseling. Very important. Then we have provision of care by skilled attendants. So it is very important to have a skilled attendant attend to you during your journey at least once, but most effectively for FANC, we advocate for 4 visits. So because you are the one who knows when your pregnancy journey started, you should make a visit very early in the pregnancy, as soon as you know you're expecting, so that you can be sent for the fetal morphology scan. And even if you not need to do the scan or you cannot afford the scan, sometimes now with the NHIF, it is possible that NHIF will pay for you for that scan so that they are able to detect if there is a problem early enough. Again, if they're able to pick up maybe a raised BP, that will be monitored so closely, and you will be booked for specialized clinic by a gynecologist or obstetrician. So you're going to be booked to special, maternal clinic, and this clinic is usually run by a qualified consultant, and you're going to get the best of the best. Then we have a number of things that you will be advised along the way, so it is very important to ensure you go for at least the 4 visits. So then, the essential elements of a focused approach to antenatal care, we have identification and surveillance of the pregnant woman and her expected child, recognition and management of pregnancy-related complications, particularly preeclampsia, recognition and treatment of underlying concurrent illnesses, screening for conditions and diseases such as anemia, STIs, especially syphilis, because that can be transferred to the child, HIV infection, because again we have the vertical transmission, mental health problems, because there is a natural risk of you developing puerperal psychosis after delivery, and then we have symptoms of stress or domestic violence. That is why I said in the roles of the midwife, in my first episode number 1, one of the roles of the midwife is to identify abuse and work with domestic abuse or violence services to ensure that the woman is taken care of and no one is being aggressive or abusive to her, especially during this time. Preventative measures including tetanus toxoid, deworming, iron, folic acid intermittent, preventive treatment of malaria, and insecticide-treated bed nets. So this has been safe, simple, cost-effective methods. So most of the places you go, you will be given a bed net. So every time I went for my clinic, with my first one I didn't get a bed net, but for my baby, when I took my baby for the first clinic, I was given a bed net for the baby. Especially if you don't sleep with the baby in the same bed, then you are covered because you're going to get the net when you go for the very first visit, and then you are going to be given another net for the baby specifically. So since I have spoken about 4 antenatal visits for this FANC or Focused Antenatal Care, it is recommended that the pregnant woman should attend at least a minimum of 4 comprehensive personalized antenatal visits spread out during the entire pregnancy, during which specific focused activities are carried to guide the woman along the path of survival as follows. The first visit is usually as immediately you recognize you are expecting, should be less than 16 weeks. Then 2 is a second visit, and this is between week 16 and between 8 to week 28. What I have seen a number of women do, especially if it's not their firstborn, second and third born, usually women will start their clinic even at week 28 because they do not want to go to clinic very many times. This could be okay if you are completely healthy. But in the event that there is a complication or an issue, you do not want to stay and delay your care because it is you to seek for that health care. So it is important to actually want to seek health care and actually do that because it is provided whether you have money or not, because most of these services are free of charge in every government facilities, and even in most mission hospitals, they are either free or close to free. They have been subsidized so much that it is affordable. You can afford this. Even if you do not have a job, you do not have a provider, you can still have these services done. So in each of the 4 visits, there are different things that are done and to ensure that the care is focused and customized for each client. So usually you'll find most MCHFP clinics will separate clients based on whatever visit they are doing, so that especially for the very first visit, they are able to give as much information, as much of the services, and prepare as much as possible that this mother will reach term and with less complications or emergencies. So the first visit, 8 to 12 weeks, this is usually to confirm the pregnancy, to have your LMP and EDG dates so that you at least have an expected date of delivery, and then to classify women for basic ANC and to know who is for specialized care, to screen and treat and give preventative measures, to develop a birth emergency plan and advise and counsel the mother. So in this first clinic is when you get your bed nets. And I think I did not get bed nets for myself both of the times. But it's not that I was offered, I refused. I actually didn't want to get. But I could have gotten, and usually it is stamped. So you are given your bed nets, you will be given your IFAS. They are going to, if you are above 12 weeks, you are going to get your first jab, your tetanus toxoid. But that again, you will be advised. A comprehensive history will be taken where they ask, check and record everything that you tell them about your pregnancy, the history of that pregnancy, and previous pregnancies and any other condition that you may have. Then a head-to-toe examination will be done. This is very important. And then vital signs are a must, and weighing, so that you're able to know like how the weight per every visit is going. Then if there is any need to treat, or an antenatal profile is done. An antenatal profile comprises of 4 tests, and this is the HB at least, or you can do the full blood count. Then they also do malaria for MPS, BS for MPS, that's the malaria test. Then they do VDRL to rule out sexually transmitted infection, specifically syphilis. And then they're also going to do, what am I leaving? So there are those 4 tests. Then you're going to get your TT or tetanus toxoid, and then iron and folate to supplement, of course. Then you're also going to come up with an individualized birth plan. You're going to receive health education on self-care, alcohol and tobacco cessation, nutrition, safe sex, rest, sleeping under the insecticide-treated bed net, birth and emergency care plan, and things like those. So always the first visit has a lot to cover. Then the issues to be covered or the things to be done in each test will go. Yeah, the 4th test is urinalysis. So urinalysis will check for infections or any other thing, just to ensure that you stay clear. And especially because it can also give a lot of information, especially regarding preventing preeclampsia and such complications. So every other visit, the other one will be 24 to 26 weeks. At this point, this is the 2nd trimester. The baby has started gaining weight, so that if there are any complications, some women at this point usually have like swollen lower limbs, or they're doing this and that, and now the weight of the baby is now starting to get thin. So different things will be done during each visit. So then on the 3rd visit, on the 2nd visit, especially if, let's say in the first visit, your blood group, yes, blood group is another test that is done. If your blood group is rhesus negative, that means it's A negative, O negative, B negative, AB negative, you will have to do a jab called anti-D, especially if it's your first pregnancy. And then with each subsequent pregnancy, you will still get. But the first jab of anti-D will be given around week 28. So during the 2nd visit, so your 2nd visit may be delayed a little bit so that you come at the 28th week and you get the jab. Then you will also get another anti-D after delivery within 72 hours. So it is very, very important to remember that. Then all along, your urinalysis should be done with every visit. Your vital signs should be done with every visit. And of course, you may need to do stool tests to rule out, to ensure that you need to deworm, because sometimes you may need to deworm and the medications to be used are not very friendly, especially in the first trimester, so they may be pushed to the other visits. So different things will be done. And then in the event that we have a HIV positive mom, there is extra precautions that are taken. You will get a lot more information on how to prevent vertical transmission, and vertical transmission is where the baby will get HIV from you. So that is prevented way early, and usually when they follow this, we achieve a HIV negative baby when they're tested at 18 months of age. So these were the references that I used for this presentation. And remember, this is episode 2. I have had to compress a lot of information. There is a lot more you need to know. But trust you me, if you have this booklet, all the information that I will talk about in this series will be provided in this booklet. So this booklet is a focused antenatal and postnatal and everything until the baby is 5 years. So if you're talking about focused antenatal clinics, you will see what will be done in every clinic. They will tell you, they will weigh you, they will do all those things. You will be given different health messages, and these health messages are to assist you. One of the things I'm going to cover as an episode on itself is recognizing minor physiological changes in pregnancies or discomforts versus danger signs of pregnancy. So that will be episode 3. Thank you so much for watching, and bye.